How many people here have had stents? A coronary stent, something put in a little, it's like a little wire mesh put into the blood vessel to open it up. Nobody here? Okay. Oh, you did have one, okay. So, and sometimes they work very well, sometimes they work very well short term, but they can be narrow. They've developed over since the 90s, these stents for the arteries, and now they're coated often with a medication to prevent the re-narrowing, but it doesn't always work 100%. It's about 95% effective. And then sometimes they have problems with allergic reactions, it's very rare, or late clotting, that's also very rare.
Can they be repeated?
Yes, they can be repeated. It depends a little bit on the geometry. If we can go back to the previous slide. Let's say, for instance, if there's a re-narrowing that were to occur somewhere in this area here, we can put a little wire and put another one there. If there's a re-narrowing inside the stent that was put in here, we can put either a new stent or it can be dilated again, and with the ultrasound we can see what's going on. Is it a blood clot? Does it need medications? Or is another stent necessary? But the idea of the coated or medicated stents is to decrease that risk. So basically with a regular, back in the, I guess in the early mid-80s, angioplasty got developed in Switzerland in the late 70s, brought to the United States around 1980. And when we were doing angioplasty back in the mid-80s and late 80s, you basically put the balloon there and then open it up and then hope that it stays open. So you wouldn't know what you'd get until you took more pictures. And sometimes we have to keep the balloons up for 5 or 10 minutes. And so balloons were developed with a little lumen or a little opening that would allow blood flow into the blood vessel. Well, when the stents came around, we didn't have to do that anymore. So with the stent, you put the balloon in, open it up, the stent gets expanded and we call it deployed or expanded. It stays open and the balloon is deflated and taken out together with the wire. So the stent stays in there as a strut, as a scaffolding. So think about it like a little bit of chicken wire, and then when you blow up the balloon, the chicken wire expands, and then the balloon is deflated again from the outside. It has little long tubes. So we have like basically a suction device. So then when it's deflated, then you take a picture with it deflated. If it looks good, you take everything else out and you're done. It can be a very short procedure. It can be as short as 30 minutes. Sometimes it can be longer. There's a lot of blockages or a lot of stents necessary. It can take as long as an hour and a half or 2 hours. But it's short of doing open heart surgery, which was the only way to treat these prior to the balloon angioplasty and the stent.
Can I ask a question? I'm just curious, what is the diameter of an artery?
Oh, well, that varies. That's a very good question. It's very technical.
Sure,
so,
but I mean maybe using fingers.
It's about 3 millimeters. This diameter here is 3.5 millimeters. Down here it's around 3 millimeters. And it does vary, and different people have different diameters, and that's one of the technical issues about the sizes of the stents and the balloons and stuff to use. Those are some of the decisions we make during the procedure. Let's see, we did the next slide. Let's go down one more slide after this. Okay, so the risks, we already talked a little bit that it can be narrow. It can be ingrowth of tissue on the bare metal stents that were first developed. Then the drug-eluting stents we've already covered. And with drug-eluting stents, you need a medication called Plavix, which in addition to the aspirin. So it does mean that you have to be on medication for a longer time to keep it from closing off.